Good afternoon, everyone, and welcome to MRF HIV STI Echo Series. This is our 98th episode. We're getting close to our century mark, so thanks for coming with us today. We are particularly pleased to welcome Dr. Erin Cleveland. She is Clinical Assistant Professor in the Division of Gastroenterology and Hepatology at Harborview Medical Center in Washington. She has particular expertise in hepatology, in hepatology, and she is going to present today on a topic that is becoming increasingly important, hepatitis B diagnosis and triple hepatitis C diagnosis and treatment. I think it's an area that we all sort of have an idea of, but some of the nuances of it sometimes slip in and out of memory. So we're very happy to have Dr. Cleveland to accompany us today and give us of her expertise. Thank you so much, Dr. Cleveland. Floor is over to you.
Great. Thanks, Greg. It's really great to be here. Go ahead and share my screen. Let's see. All right. Does that look all right?
Yes, looks good.
Perfect. Well, I'm very happy to be here today talking with you all about viral hepatitis. I hope this will be a useful session and happy to take any questions at the end. My learning objectives for today are to describe the epidemiology, transmission, and natural history of hepatitis B and hepatitis C infection, identify target populations for screening, understand which patients with chronic hepatitis B are likely to benefit from antiviral treatment, and identify our recommended first-line medications, recognize patients who are at risk for hepatitis B reactivation, and understand when to initiate prophylactic treatment. And then finally, to understand a pre-treatment evaluation for patients with hepatitis C and use a simplified treatment algorithm. I will give two disclaimers. One is that this is a huge topic that couldn't be, possibly covered in its entirety in an hour. So I've tried to highlight key points. And again, I'm happy to take questions. And the second is just that I, practice in the US. And so I assume there will be some practice differences between us, but I'm hopeful that that can be a jumping off point for a conversation at the end. So we'll start with hepatitis B, which I would argue is the slightly more cumbersome and sometimes confusing topic. So we'll get it out of the way with first. Hepatitis B infection represents a significant public health burden worldwide, with an estimated 254 million people living with chronic hepatitis B globally in 2022. In that same year, over 1 million new hepatitis B infections were estimated. And the high prevalence of chronic hepatitis B globally is largely driven by mother-to-child transmission at the time of or shortly after birth, as those perinatal infections lead to a high rate of chronicity. This global health burden has led the WHO to put forth a viral hepatitis elimination goal, which they define as a goal of a 90% reduction in new cases and a 65% reduction in mortality by the year 2030. And this is, largely going to be through preventative measures, including vaccination, prevention of maternal transmission, as well as screening and linkage to care, which we'll talk about today. Unfortunately, hepatitis B remains an underdiagnosed and undertreated disease globally. According to WHO estimates, only about 13% of people in the world with chronic hepatitis B have been diagnosed, and even fewer are receiving therapy. So this really highlights the work that we have to do. Hepatitis B is transmitted via percutaneous or mucous membrane contact with infected blood or bodily fluids. And the most common routes of transmission vary by regions. In endemic regions, vertical transmission from mother to infant in the perinatal period is the primary source of infection. Child to child horizontal transmission is also quite common in high prevalence regions, whereas in low prevalence regions, transmission occurs more commonly through sexual activity or injection drug use. And in fact, in the United States, injection drug use is now the most common cause of new hepatitis B infections. The mode of hepatitis B transmission strongly influences the risk of developing chronic infection. Those who are infected via vertical transmission early in life are at highest risk for going on to develop chronic infection. About 90% of infants infected via vertical transmission will develop chronic hepatitis B. In contrast, the vast majority of adults who are affected or infected with hepatitis B will actually go on to clear the virus. Less than 5% of them will develop chronic infection, and those infected in childhood are somewhere in between. People who do progress to chronic hepatitis B are at risk for significant morbidity and health related complications, including cirrhosis, hepatic decompensation, liver cancer, and death. Fortunately, hepatitis B is preventable with immunization. Hepatitis B vaccination is highly effective, particularly when given in infancy or childhood, with about 95% immunity achieved among individuals under the age of 19 who receive a full 3 vaccine series. The WHO recommends that all infants should receive the first dose of hepatitis B vaccination as soon as possible after birth, preferably within 24 hours. And that birth dose should be followed by 2 or 3 additional doses to complete the primary immunization series. The WHO recommendation for universal infant Hep B vaccination was first made in 1991. And since that time, we have seen marked improvements in immunization rates. I think this graph, it's small, hard to see, but is from 2000 to 2022. And you can see that the rates have gone up, although they've plateaued over the last few years, with about 80% of infants globally receiving the 3-dose series within 1 year. Based on the most recent data I could find, the rate in Trinidad was about 96%, so well above the global average. In contrast, however, there's clearly still work to do. You can see that for the birth dose within 24 hours, less than 50% of infants are meeting that mark. We're not getting people that first vaccination dose within 24 hours of birth. So still room to improve here. In addition to vaccination, screening is a key tool to address the worldwide burden of viral hepatitis and identify individuals living with hepatitis B in order to link them to appropriate care. Hepatitis B surface antigen, which is the primary marker of active infection, can be used for screening. And the WHO recommends screening all adults who are living in high prevalence regions, which is defined as greater than 2% hepatitis B surface antigen positivity in the population. From the data I found, it looks like Trinidad falls just under that 2% range. I didn't actually explicitly mention it on my first slide, but the prevalence of hepatitis B globally varies significantly by region and is particularly high in sub-Saharan Africa and East Asia, with some countries having greater than 20% prevalence of surface antigen positivity. In addition to people from high prevalence regions, the WHO recommends screening all blood donors, all pregnant people, and the following high-risk groups: migrants from endemic regions, family members of infected individuals, people who inject drugs, people who are incarcerated, individuals with higher sexual risk practices, people living with HIV, and healthcare workers. We also recommend testing for hepatitis B among anyone who has potential signs or symptoms of acute infection, which would be jaundice would be the big one. People with elevated liver tests, a known recent high-risk exposure, anyone who's going to be receiving immune suppressive therapy, which we'll come back to, and then people on hemodialysis. There are a number of hepatitis B serologies, and these can sometimes be a source of confusion, so we'll just take a minute to review the different tests. Hepatitis B surface antigen is the main envelope protein of the intact hepatitis B virion, and the presence of hepatitis B surface antigen indicates active infection. The hepatitis B surface antibody binds to surface antigen on intact virions, and the presence of surface antibody indicates either recovery from natural infection or prior immunization. And this is a protective antibody. The hepatitis B core antibody forms in response to the core antigen that's part of the inner viral nucleocapsid. And it indicates a history of past infection. And importantly, it is not protective, unlike the surface antibody. The E antigen is a secretory protein that's released by the virus into circulation and generally reflects high levels of viremia and infectivity. The E antibody acts against the E antigen, and it generally corresponds with a decrease in hepatitis B DNA levels and a more favorable immune response to the virus. It is also not protective. And then finally, hepatitis B DNA can be measured directly and also indicates active infection. So using 3 of these tests, the surface antigen, the core antibody, and the surface antibody, we can determine what most people's hepatitis B status is. As we discussed, people with chronic infection will have a positive surface antigen. They will also have a positive core antibody, but will not have surface antibody. Patients with hepatitis B core antibody is always indicative of previous infection. So the presence of core antibody and surface antibody indicates past infection that has now resolved. If people have an isolated surface antibody but no core antibody, that means they are immune through vaccination. An isolated hepatitis B core antibody can mean a few things. Most commonly, this is due to past exposure or cleared infection with waning of surface antibody titers over time. So in some individuals, over time, the surface antibody can disappear. Less commonly, this could be due to occult chronic infection with loss of the surface antigen. Usually people in that setting have very low DNA levels. And then finally, it could be a false positive. And then lastly, if people are negative for all 3 tests, that means they've never been infected and they are not immune. You may have seen similar tables to this before. Just these graphs show the typical serologic course of acute and chronic hepatitis B infection. In acute infection, the hepatitis B surface antigen will become detectable about 4 weeks from the time of inoculation, and the core antibody will appear soon thereafter. The appearance of surface antibody here in blue generally follows a decline in the hepatitis B surface antigen and indicates clearance of the virus. Again, this is protective and generally will persist for life. It's important to remember, though, that even people who have cleared hepatitis B infection, as indicated by a negative surface antigen, still remain at risk for reactivation of disease later in life due to persistence of hepatitis B DNA within the hepatocyte nucleus. People who do not clear acute infection will progress to chronic hepatitis B, which is defined by the persistence of hepatitis B surface antigen beyond 6 months. In this case, the hepatitis B core antibody will appear in the same way as in acute infection, but the surface antibody will not appear. I'm going to take just another minute to talk a little bit more about the natural history of chronic infection, as it helps us to understand which patients we should target for treatment. I like to think of the physiology of hepatitis B infection as sort of a battle between the hepatitis B virus and the host immune system. The hepatitis B virus does not directly damage hepatocytes. However, it can lead to activation of the host immune response, and it's that host immune response that actually leads to hepatocyte injury and, over time, fibrosis or scarring formation within the liver. And the natural history of chronic hepatitis B infection involves several virologic phases. Individuals who are infected in infancy or early in life will begin in what's called the immune tolerant phase, where they have very, very high hepatitis B DNA levels, often in the many millions, but have normal ALT levels and very minimal evidence of immune activation. The immune system essentially tolerates very high levels of virus. So if you were to biopsy these people, they'd actually have very minimal signs of inflammation and generally no scarring on liver biopsy. However, at some point in life, often in people's sort of mid-20s, although that's variable, we can see that the hepatitis B DNA levels start to decline. And with that, we'll see spikes in people's ALT levels as the immune system all of a sudden starts to recognize the hepatitis B virus and tries to eradicate it. And it's during this phase that we start to see significant liver inflammation and potential progression of liver fibrosis. If the immune system is able to win this battle, people can move into what's called inactive chronic hepatitis B, where the hepatitis B virus is suppressed and there's not ongoing active liver inflammation. That's characterized by low hepatitis B DNA and low ALT levels. And however, in some patients, we can see sort of a resurgence in the immune response and hepatitis B DNA levels. And again, we would see rising DNA levels with rising ALT. And this is another phase where people are at risk for having progressive liver fibrosis. And then finally, if people are able to sustainably suppress the virus, they may lose surface antigen, which is the marker of resolved infection, or what we call a so-called sort of functional cure. And it's really these two phases, the immune active E antigen positive phase and the immune active E antigen negative phase, where people are most likely to benefit from treatment. So we'll move now into talking about hepatitis B treatment with that framework in place. The overarching goals of hepatitis B treatment are to improve survival by preventing cirrhosis, liver cancer, and death. We also want to prevent vertical transmission and viral reactivation. There are some specific therapeutic goals we use when treating people with medications for hepatitis B. These include an undetectable serum hepatitis B DNA level, improvement in liver inflammation, which we use the ALT level as a surrogate for that, so ALT normalization. In people who are initially E antigen positive, loss of the E antigen and development of an E antibody is a favorable sign that tends to indicate improved immune suppression. And then, as I mentioned, our ultimate goal is surface antigen loss, or what we call functional cure, although, as we'll talk about, this is unfortunately a rare occurrence with Hep B therapy. Because we aren't able to completely eradicate hepatitis B infection, and because of the fact that most people who start on therapy will need to continue it lifelong, we don't necessarily recommend treatment for all people with chronic hepatitis B. Instead, we target those who are at highest risk for liver-related complications, and there are three primary factors to consider when evaluating whether someone would benefit from antiviral therapy. And those include the hepatitis B viral load, the ALT level, which is a marker of liver inflammation, and then fibrosis, which again is liver scarring, and progressive fibrosis ultimately can lead to cirrhosis. In order to decide who should receive treatment, there's some initial testing that we should do. That includes a hepatic function panel so that we can evaluate the ALT, a hepatitis B DNA level, and then some form of non-invasive fibrosis testing. So this includes serologic-based scores like the fibrosis 4 FIB4 score or the APRI score, which use commonly available data points, including age, transaminase levels, and platelet count, to estimate whether someone is likely to have advanced fibrosis or liver scarring. Transient elastography, which is most commonly done via the FibroScan machine, is another way to estimate liver scarring by estimating liver stiffness. So generally, people with more liver scarring are more likely to benefit from Hep B therapy. So who to treat? This is a little bit more complicated, and our guidelines vary depending on where you look. So I've compiled here a summary of guidelines from the major liver-related societies, including the American Association for the Study of Liver Disease. You'll note that these guidelines at this point are all a bit outdated, and we are anticipating some new guidelines likely within the next year, which may lead to a change in some of these recommendations. But at present, we recommend treating anyone with cirrhosis and a detectable viral load, regardless of what their ALT level is. And then we recommend treating people with immune active disease, which again, we define by the presence of an elevated ALT and an elevated viral load, with cutoffs listed here. Additionally, we would suggest considering treatment for people who have signs of significant fibrosis or inflammation on liver biopsy, but really more so fibrosis via non-invasive testing, but who otherwise don't meet thresholds for treatment. We would also consider treating individuals above the age of 40 with an elevated viral load, as we know these people are at increased risk for liver fibrosis progression. I've also included the WHO guidelines here. They just released a new guideline this year, and their guidelines, I think, are a little bit more straightforward. They, again, suggest treating anyone with cirrhosis, and then they explicitly state that individuals with evidence of significant fibrosis based on non-invasive testing should also be treated. They also suggest treating people with immune active disease, but simplify the cutoffs for that, a DNA of greater than 2,000 and an ALT greater than the upper limit of normal. They also suggest for people to treat people with persistently elevated ALT if DNA testing is not available, and then to treat anyone with co-infection with HIV, hepatitis D, or hepatitis C. Very briefly, I will say that acute hepatitis B, as we talked about, generally clears, and most individuals with acute hepatitis B do not require treatment. We might consider treating those with severe acute infection as evidenced by elevated bilirubin, INR, or signs of decompensated liver disease, or people who have a particularly prolonged course. For treatment of chronic hepatitis B, nucleoside analogs are our mainstay of treatment. It's important from the outset to use highly effective nucleoside analogs to prevent the development of viral resistance. And our more recently developed drugs, which include entecavir, tenofovir disoproxil fumarate, and tenofovir alafenamide, all have very, very low rates of viral resistance when compared to older generation drugs such as lamivudine. And because of this, we recommend using one of these three agents as first-line therapy. All of our first-line nucleoside analogs are administered via once-daily dosing. Entecavir, it's worth noting, does have a slightly increased risk of resistance if people have previously been treated with lamivudine, so should be avoided for people with previous lamivudine exposure. TDF does carry an increased risk of renal dysfunction and impacts on bone density. So we avoid this agent if possible in people who have CKD or osteoporosis, although it is our preferred agent in pregnancy due to the most safety data. And then TAF, which is our newest drug, does not carry the same risks, renal and bone-related risks as TDF. So it's appropriate for use in these groups. I've also included PEG interferon here, which is still recommended as a first-line treatment in our US guidelines, but I will tell you in clinical practice, it is very rarely used because it is so poorly tolerated with a lot of side effects that often lead to its discontinuation. In terms of monitoring on treatment, we recommend assessing for adherence at every visit. And then per the WHO guidelines, it's recommended to monitor a hepatic function panel, hepatitis B DNA and serologies, and some type of non-invasive fibrosis testing at least annually, with consideration for more frequent monitoring early on in treatment and in individuals with either advanced liver disease, HIV co-infection, or renal impairment. Because of the renal-related risks of TDF, we do recommend periodically monitoring creatinine while on that therapy as well. And then if people are not on treatment, it's important to recognize that they should not, we should try to avoid letting them fall out of care. We should continue to monitor their hepatic function panel and hepatitis B DNA tests at least annually to continue assessing whether at some point they might meet criteria for treatment. Unfortunately, as I've mentioned, hepatitis B surface antigen loss, which is really our primary or gold standard endpoint for treatment, is very rare among patients who are treated with our first-line agents, particularly nucleoside analogs. And this is especially true for individuals who are E antigen negative. You can see rates of surface antigen loss with our 3 drugs here are all very, very low. And so most patients who are started on nucleoside analog therapy will require lifelong treatment. In rare situations, we might consider discontinuation of therapy if they meet particular endpoints. So for people who have a positive E antigen, if they lose their E antigen and get at least a year of consolidation therapy, or if they lose surface antigen, we could consider discontinuation. For E antigen negative patients, surface antigen loss is really our only treatment endpoint. And then, as I've said, people with cirrhosis should be on indefinite therapy. If stopping therapy, it's very important to monitor labs closely because people can be at risk for reactivation or flaring after therapy is stopped. Liver cancer screening is an important component of management for our patients with hepatitis B and is usually performed with liver ultrasound and alpha-fetoprotein every 6 months. Patients with hepatitis B and cirrhosis are at highest risk for liver cancer, and both the AASLD and WHO agree that patients with cirrhosis should have liver cancer screening. However, patients with hepatitis B who do not have cirrhosis are still at risk for liver cancer, although that risk is smaller than in individuals with cirrhosis. Both the AASLD and WHO agree that people who have a family history of HCC should be screened. Additionally, the AASLD recommends screening based race and age-based screening, as well as screening for those with hepatitis D co-infection. The WHO suggests screening in older individuals who have an elevated viral load, given a higher risk of liver cancer in this group. Lastly, I'm going to focus in on the management of a few specific populations. The first is pregnant individuals. One of our primary aims of Hep B treatment is to prevent vertical transmission. Universal screening for hepatitis B infection is recommended for all pregnant people at the first prenatal visit. That should be done with a hepatitis B surface antigen. And if people have a positive surface antigen, they should be assessed for whether they meet criteria for treatment of immune active disease. So if they have an elevated DNA and an elevated ALT, they should be started on therapy. And the preferred agent, as I've said, during pregnancy is TDF. If patients don't otherwise meet criteria for treatment of chronic hepatitis B, a hepatitis B DNA level should be checked in the late second trimester, because the hepatitis B viral load is the most important predictor of the risk of vertical transmission. So for people who have a low viral load, it's reasonable to continue routine care without prophylaxis. However, individuals with a viral load of greater than 200,000 should be started on treatment from the end of the second trimester through at least birth. All infants born to mothers with hepatitis B should receive hepatitis B vaccination and hepatitis B immunoglobulin within 12 hours of birth. Importantly, breastfeeding is not contraindicated in mothers with chronic hepatitis B on or off therapy. Hepatitis B and HIV co-infection is an important area to touch on. About 1% of people living with hepatitis B globally are co-infected with HIV. And we have good evidence that patients with co-infection have worse clinical outcomes than those with either HIV or Hep B monoinfection. It's recommended that all patients with hepatitis B be screened for HIV, and all individuals with co-infection should receive concomitant treatment that is active against both HIV and Hep B. Specifically, antiretroviral therapy should include 2 drugs that are active against hepatitis B, generally tenofovir and either lamivudine or emtricitabine. Entecavir should be used with caution in individuals with co-infection. And when used, it should only be given if people are receiving a fully suppressive antiretroviral regimen, because there is a potential risk of HIV resistance mutations if people are treated with entecavir monotherapy. And then finally, it's important to counsel individuals on the risk of a hepatitis B flare if their therapy is stopped or interrupted. And that includes individuals who are with Hep B who are on pre-exposure prophylaxis. Hepatitis D or hepatitis delta infection, hepatitis D virus is an incomplete RNA virus that requires the presence of hepatitis B for the virion assembly and secretion. So hepatitis D infection only occurs in people who have chronic hepatitis B, and it's estimated that about 5% of people with hepatitis B globally have hepatitis D co-infection. Hepatitis D infection is associated with a significantly increased risk of liver decompensation, liver cancer, and death. Hepatitis D screening is done initially with a hepatitis D antibody, and if that's positive, can be followed up with a hepatitis D DNA level. Our US-based ASLD guidelines recommend risk-based screening, but the recent WHO guidelines suggest universal screening for all individuals with hepatitis B, I think to decrease complexity and lower the barrier to testing. Unfortunately, we don't have great options for treatment of hepatitis D at this point. The nucleoside analogs are not active against hepatitis B. And until recently, the only therapy that we've had is pegylated interferon, which I've mentioned has many potential side effects and is often poorly tolerated. It should be given for at least 48 weeks. And even with that, only about 30% of individuals will have a suppressed hepatitis D RNA level. More recently, bulevirtide, which is a medication that inhibits entry of hepatitis D into hepatocytes, was conditionally approved in some parts of Europe for treatment of hepatitis D. This has to be taken chronically, and as I mentioned, at this point, it's still not available in most parts of the world. And then the last thing about hepatitis B that I'll touch on is hepatitis B reactivation, which is defined as loss of immune control of inactive or resolved hepatitis B infection, and generally occurs in the setting of immunosuppressive medications. It's characterized by an abrupt increase in viral replication that leads to liver damage resulting from the immune response. And it can occur in individuals with chronic inactive hepatitis B with a positive surface antigen, or in people with resolved hepatitis B who have a negative surface antigen but positive core antibody. The severity can range from subclinical to acute liver failure and death, and this really does happen. I think every hepatologist has at least one horror story of somebody who's had a very bad outcome related to Hep B reactivation. And so it's really important that anybody who's going to be receiving immune suppressive therapy should have testing for hepatitis B prior to starting treatment. And that should be with surface antigen, surface antibody, and core antibody. We can then risk stratify people into high, moderate, and low risk for reactivation based on the pattern of their serologies. People with a positive surface antigen are going to be at higher risk for reactivation than those with just a positive core antibody. And then based on the medication that they're going to be receiving, with the highest risk drugs being B-cell depleting agents such as rituximab. SCT is stem cell transplant, also a very high risk. And then based on their risk category, we can make a decision on whether to treat them with prophylaxis, so put them on a nucleoside analog, or closely monitor their hepatitis B labs. And a number of these tables can be found online. I think the key point here is to remember to test for hepatitis B prior to immune suppressive therapy. And with that, we can take a breather because that was a lot of information. We'll switch gears now and talk about hepatitis C for the rest of the time, which, as I mentioned, I think is generally a bit more straightforward of a topic. Before we get into this section, I just want to put in a plug for the ASLD and IDSA, the Infectious Disease Society of America, guidelines, which were put out a few years ago by the two societies and can be found at hcbguidelines.org. This is just a very comprehensive and easy to use website that really walks you through hepatitis C treatment for most any scenario or sort of patient that you could imagine. So I use these guidelines frequently. I would highly suggest saving this as a resource. Hepatitis C is estimated to affect over 50 million people worldwide. And at least in the United States, we are seeing significant increases in the incidence of new infection over the last decade, disproportionately among younger individuals. This parallels the opioid epidemic in the US, as far and away the most common mode of transmission of hepatitis C is through injection drug use. One study showed that among individuals who inject drugs in North America, over half of them had a positive hepatitis C antibody indicating current or prior infection. Other potential routes of transmission include perinatal transmission with about a 5% risk among mothers with hepatitis C, sexual transmission, which is much less common than with hepatitis B, sharing of contaminated personal items, needle exposure, and historical blood transfusion prior to routine testing of blood samples. Unlike hepatitis B, most adults who are infected with hepatitis C will go on to develop chronic infection. Generally, the hepatitis C RNA becomes positive within 2 to 3 weeks of exposure, and the antibody will then become positive about 2 to 3 months later. And this antibody will persist lifelong. Cirrhosis develops around 20 to 30% of people with chronic infection, but does take decades to develop. There's a higher risk of going on to have cirrhosis in people with chronic alcohol use or other chronic liver diseases such as hepatitis B or steatotic fatty liver disease. There's also a higher risk in individuals with HIV co-infection. Both the WHO and the AASLD recommend screening all adults for hepatitis C infection. Additionally, the AASLD suggests risk-based testing for individuals under 18 years old and annual testing for those at increased risk for infection, including persons who inject drugs. Generally, hepatitis C screening is done with a hepatitis C antibody, which, if positive, needs to be followed up with a hepatitis C RNA level, which is what actually confirms active infection, or if that's not available, a hepatitis C core antigen test. More recently, point-of-care hepatitis C RNA testing has been developed. This was just approved by the FDA in the US within the last year. So that can allow for rapid turnaround of results and better linkage to care. Because it is important if obviously people have a confirmed infection that they are linked to treatment. Before initiating therapy for hepatitis C, we recommend checking a CBC, a CMP, a hepatitis C RNA level, again, to confirm infection. Most people actually don't need a genotype checked because, as we'll talk about, our first-line agents now are active against all hepatitis C genotypes. Patients should have screening for hepatitis B and HIV. And for anyone who could be pregnant, we recommend screening with a pregnancy test. Like for hepatitis B, we should perform non-invasive fibrosis staging using a serologic or imaging-based test prior to treatment to identify individuals with cirrhosis who might need ongoing liver cancer screening. And then it's important to check for drug-drug interactions, as our hepatitis C therapies do have some key interactions, including with the medications listed here. I'll call out the University of Liverpool Hep Drug Interactions website, which is a super helpful tool that allows you to enter Hep C meds and then basically enter a patient's medication list, and it will highlight all of the key drug-drug interactions. Treatment is recommended for all patients with hepatitis C, with the exception of those with a limited life expectancy who are not likely to benefit from treatment. And this recommendation is really driven by the fact that the treatment of hepatitis C has undergone a massive transformation over the last decade with the introduction of highly effective direct-acting antiviral treatments. Historically, interferon was the primary treatment for hepatitis C, but was plagued by a high rate of treatment failure and, again, very severe, often intolerable side effects. But in 2011, the first direct-acting oral antiviral agent was approved in the US, and since then, a number of other medications have been approved, including several pan-genotypic drugs, which allow for, again, treatment of individuals with all genotypes. There are now multiple approved regimens for every genotype. Luckily, you do not need to memorize this table. I'll just highlight that, again, these medications are highly effective with cure rates exceeding 95%. With the introduction of our pan-genotypic regimens, the AASLD and IDSA have created an algorithm for simplified hepatitis C treatment to try to help increase uptake of hepatitis C treatment in primary care and non-specialty settings. And this is appropriate for use in people who have chronic hepatitis C, have not previously been treated with another direct-acting antiviral, and who either have no cirrhosis or compensated cirrhosis. We don't recommend using this if people have received DAAs previously, if they have decompensated cirrhosis, co-infection, are pregnant, have liver cancer, or have previously had a liver transplant. So for patients meeting those criteria who don't have cirrhosis, the options are very simple. either glecaprevir pabrentasvir for 8 weeks or sivosbuvir velpatasvir for 12 weeks. The first is 3 pills taken once a day, and the second is 1 pill taken twice a day. An alternative option recommended by the WHO is sivosbuvir declatasphere for 12 weeks. This is no longer available in the US, so we don't use it here, but it is commonly used globally. And then for individuals with compensated cirrhosis, it's almost exactly the same, except for that patients who have genotype 3 infection, we recommend baseline testing for the Y93H resistance mutation, because those individuals have a lower cure rate when treated with Sofvel. And so we would recommend addition of ribavirin for those folks. And again, this is all outlined in the HCV guidelines website that I mentioned previously. Luckily, these drugs are generally very well tolerated with minimal, if any, side effects. And for most individuals, we actually don't need to do any on-treatment lab monitoring. We do suggest periodically checking liver enzymes for patients with cirrhosis and recommend monitoring liver enzymes and or Hep B DNA levels for people with Hep B co-infection, as we'll talk about. A hepatitis C RNA level should be checked 12 weeks after completing therapy to confirm cure, which is defined as negative Hep C RNA at 12 weeks, which is what we call the sustained virologic response, or SVR12. I'll highlight a few special populations here. The first is individuals with decompensated cirrhosis. Generally, these are people who should be monitored in a specialist setting and potentially referred for liver transplant if and where that's available. But it's important to avoid regimens that contain protease inhibitors because the medication concentration in decompensated cirrhosis can be significantly increased. For people who've had prior DAA treatment failure, we do now have a highly effective medication, Sofvel Vox, or voxileprevir, which is given for 12 weeks. For people who have hepatitis B co-infection, there is a small risk of hepatitis B reactivation during hepatitis C treatment. So if people have a positive surface antigen, they should either be started on hepatitis B therapy or have Hep B DNA levels monitored monthly and started on treatment if those increase significantly. For people who are surface antigen negative, we should monitor their liver tests monthly and check a Hep B DNA level if the liver tests rise. The reactivation risk is significantly lower in this group. For hepatitis C HIV co-infection, really the biggest factor here is potential drug-drug interactions with the antiretrovirals. And that's where using an interaction checker like the University of Liverpool tool is really important. It's worth noting that HIV therapy should not be paused to allow for Hep C treatment, although in some cases people may need their antiretroviral regimen switched to avoid drug-drug interactions. And then finally, I think this is really one area that we still have a lot of work to do in hepatitis C. Currently, hepatitis C treatment is not recommended during pregnancy, mostly because of a lack of clinical trials in this patient population. There are some very small studies, sort of proof of concept studies that suggest overall safety of DAAs in pregnancy. But this is still not recommended, nor is it a common practice at this point. Following cure of hepatitis C, patients who do not have cirrhosis can be treated with routine care as if they have never had Hep C infection. They should be assessed for hepatitis C. I said recurrence here, but really this is reinfection. If they have risk factors or new unexplained elevated liver tests or hepatic dysfunction. And once someone has been infected, retesting has to always happen with a hepatitis C RNA level because the antibody will remain positive lifelong. For people who have cirrhosis prior to treatment, we do recommend ongoing liver cancer screening with ultrasound and AFP levels every 6 months because the risk of liver cancer does persist beyond hepatitis C cure. And then finally, patients should be counseled that the hepatitis C antibody is not protective and they do remain susceptible to reinfection. So with that, a few take-home points. Hepatitis B immunization is recommended for all infants with the first dose ideally given within 24 hours of birth. Individuals who are living in or from high prevalence hepatitis B regions should be screened. We should also screen all pregnant individuals and people with risk factors for infection. Hepatitis B treatment is recommended for people with cirrhosis, immune active disease, significant fibrosis, or HIV or hepatitis delta co-infection. Entecavir and the 2 formulations of tenofovir are first-line treatments for hepatitis B. Hepatitis C treatment is recommended for essentially all individuals, except those with a very limited life expectancy. And then our recommended regimens for uncomplicated hepatitis C treatment are listed here. Just a few helpful resources that I'll point out. Like I said, the WHO just put out new hepatitis B guidelines this year, which are very comprehensive. The AASLD and IDSA guidelines that I mentioned. And then one other resource that's through the University of Washington where I work is called Hepatitis B and Hepatitis C Online. And this is really aimed at practical guidance for primary care and general practitioners, and it's very easy to use. So all of these are very trusted and good resources. And with that, I'm happy to take any questions people might have.
Thank you very much, Dr. Cleveland. I think it's always so instructive to have one of those lectures because we always get the antibodies mixed up and which combination treatments. That was really, really helpful. Thank you so much. Because no matter how many times you read, I still get mixed up. That was very clear. Thanks so much. I will leave the floor open for any questions. I have a few as usual, but I'm not going to hog the mic. Anyone has any questions to Dr. Cleveland? See nobody yet. I'm not seeing any hands up. So good. I do get to hog the mic. So just as a clinical question. Tenofovir was not always available. So some of the patients who were HIV, hepatitis B co-infected, let's say from 2002 when treatment became available, were on regimens like lamivudine, zidovudine, lamivudine, stavudine, lamivudine, abacavir. So they would have gone for a very long time, essentially on lamivudine monotherapy for hepatitis B. And when tenofovir became available, sorry, hold on, there's a silence. So when tenofovir became available and we started monitoring the HPV DNAs, they didn't suppress completely. They would have gone down to like low 2000s HPV DNA on tenofovir, let's say, and continue on lamivudine or to emtricitabine. How do we follow those patients up? Because we don't have access to some of the other drugs that entecavir is not available. Peginterferon is essentially priced in a new SUV, so it's not sustainable for a lot of our clients. How do we monitor? Is there anything else we can do to try to achieve suppression?
Yeah. So just to make sure I'm hearing you correctly, what you're saying is folks who are on with folks with HIV and Hep B co-infection who don't necessarily have full viral suppression despite a regimen containing both tenofovir and either lamivudine or emtricitabine.
Right. Who would have had a history of prolonged lamivudine monotherapy? Let's say who would have been infected 20 years ago and tenofovir wasn't available. All right. So lamivudine for a decade.
So I guess the first thing that's helpful is that there's essentially no reported resistance to tenofovir in the literature. And so unlike with entecavir, you don't have to worry so in people who have had previous lamivudine exposure, who are then treated with entecavir for Hep B, there is an increased risk of resistance to the entecavir, but that's not true with tenofovir. So certainly anytime I'm seeing a persistent positive viral load in someone who's on tenofovir, I do always want to make sure to assess for adherence, because it is generally a quite effective drug. So if people aren't achieving viral suppression, there's a question of whether they are taking the medication routinely. But some people, it can be challenging to get full viral suppression, particularly in people who are e-antigen positive. So people in that immune tolerant phase who start off with very high viral loads in the millions. Sometimes we will see that for years they may have sort of low level persistent viral levels. Generally, we don't necessarily recommend adding a second agent, although anecdotally, I can tell you, especially I've heard this from some of my ID colleagues here who treat more HIV Hep B co-infection, that sometimes they will add a second agent, namely entecavir, and we'll see that come down and then can eventually often remove entecavir and see that people do well. But, if entecavir is not available, then you're sort of limited to leaving them on that regimen, and there's not necessarily something else, unfortunately, to do. It's just important to monitor them over time and make sure that they're aware not to stop therapy, because that's when we worry about the risk of viral reactivation, which I think is the scary possibility in that group. And then also to, monitor their non-invasive fibrosis test over time. I think that's another big sort of advance that we've seen in the last couple of decades, the use of these serologic-based scores, which are generally readily available because they're based on readily available lab tests. And if people are showing signs of fibrosis progression over time, considering whether they would be, whether we should think about screening them for liver cancer in particular. But yeah, unfortunately, sort of limited in terms of additional options for trying to achieve that full viral suppression, particularly if entecavir is not available.
See, I'm seeing a message in text that welcome to some of our colleagues in Haiti. Hi, good day. Let's see. The questions just yet. All right. Second question from me until anybody else asks anything. I know I'm hogging the mic. PIB4 APRI versus transient elastography. How comparable are they in our civil setting?
Yeah. So transient elastography, or the brand name for the machine is FibroScan. Some people might be more familiar with that. I'm not sure if you have a transient elastography available in Trinidad or not, but do you?
Well, I don't think it's available in public service very much.
Okay. Yeah, even in the US, it's often limited to more tertiary care settings, but it has a slightly better sort of receiver operator curve than either of the serum-based scores, either APRI or FIB4. Neither our serum-based scores or imaging-based fibrosis, non-invasive fibrosis testing are perfect. So I think that's the first thing to recognize, that all of these have to be taken within clinical context, and they're best at ruling out significant fibrosis. So a low APRI or low FIB4 score is going to have a better negative predictive value than a high score for positive predictive value. So that's really the best use of them. So transient elastography probably slightly better at predicting advanced fibrosis than the serum-based scores, but ultimately I think the serum-based scores, not only in viral hepatitis, but in some of our other chronic liver diseases are really our recommended first-line tests, because they're so readily available and essentially don't add cost to care. And so I think those are very appropriate tests, and they can be easily monitored over time with labs. So assessing for change.
Okay, so I think we're just at 2:59, so just about ready to wrap up. So again, I want to thank everyone for coming in a slightly gloomy and slightly cold, at least for Trinidad, Friday afternoon. Thanks so much for your time, and thank you, Dr. Cleveland, for what was a fabulous presentation. I really learned a lot. So just a quick housekeeping note. We will be off for October, and our next session will be on the 22nd of November, which is Friday, November, where we're actually hoping to have a conversation about some information from the International AIDS conference that was recently completed. I think some of our staff went up, so we're hoping to maybe have them come in and have a chat about what studies really impacted them as well, because that's one of the really impactful studies, because impactful conferences, because there's both the scientific part as well as the community part. So there's so much to learn on both areas when it comes to managing people living with HIV. So again, thanks from MRFTT STI ECHO. I'm Dr. Boyce. Thanks, Conrad, for all your assistance in the background, and we shall see you again in 2 months' time. Take care.